everyone. Welcome to Coffee Up First. I'm Amanda B. I am one of the content producers for Science Up First. And the idea behind these sessions is to bring amazing experts to you, our wonderful audience, to get a little look behind the screen at the people that do amazing things and what they get up to and who they are. I'd like to begin today by acknowledging I'm joining you from Lethbridge, Alberta, Sigokatoki, which is located on the Blackfoot territory named the Siksika-Sitapi, the Blackfoot Confederacy. Today, 4 nations make up the Siksika-Sitapi: the Kainai tribe, the Abadozi Pagani or Pagani Nation, the Siksika Nation in southern Alberta, as well as the Amskapi Pagani or Blackfeet tribe of northern Montana. As both the traditional and current land keepers of this area, the Blackfoot nations have welcomed people from other Indigenous territories, including all signatory nations of Treaty Number 7, members of the Métis Nation of Alberta Region 3, and non-Indigenous people who have come to call the city of Lethbridge home. I encourage everybody here to take a moment to reflect on the traditional territories on which you live and your relationship between the land and its history. And now I'm joined today by 3 amazing experts to discuss the very important topic of endometriosis and the misinformation that surrounds it. Dr. Natasha Orr is a postdoctoral researcher at the University of British Columbia in the School of Nursing. She's focused on exploring the role of central sensitization in endometriosis-associated chronic pelvic pain, as well as advancing the science and practice of medical education for healthcare providers and people with endometriosis using patient-oriented research. Okay. Kate Wahl is a graduate student researcher and advocate focused on advancing the health of women and gender diverse people. Kate volunteers as the executive director of EndoAct Canada, an unincorporated not-for-profit organization that aims to improve the lives of people with endometriosis in Canada by driving policy action that is based on science and grounded in the needs of the endometriosis community. And Rachel Langer is a screenwriter for dramatic television. She currently serves as a writer and executive producer on the critically acclaimed hit series Transplant. Rachel's also a published essayist focused on chronic illness and reproductive health. She also serves on the Patient Research Advisory Board for the Center for Pelvic Pain and Endometriosis, advising on research and advocacy initiatives. Well, that's a very impressive lineup we have here, ladies. Thank you so much for joining us. I know your time is very short, so let's get right into it if that's okay with everybody.
Let's do it.
All right, let's start with Natasha. Natasha, could you tell our audience what exactly an endometriosis is and who it affects?
Yeah, of course. So thank you. So endometriosis is a condition where cells similar to the ones that line the inside of the uterus are growing abnormally outside of the uterus. And these cells or tissue can grow on various structures, such as the bowel, the ovaries, even on the outside of the uterus. And sometimes they can even grow in faraway locations like the lungs. And there are 3 types of endometriosis: superficial endometriosis, deep infiltrating endometriosis, which are when the lesions are forming or invading a little bit deeper into the tissue, as well as endometriomas, which form cyst-like structures on the ovaries. And so in terms of who it affects, endometriosis affects approximately 1 in 10 women in an unmeasured number of diverse people. So 1 in 10, that's 10% of people. So that's a very common condition. And despite some myths out there, endometriosis can affect adolescents and can affect people who are postmenopausal.
And maybe just to get you to follow up on that, Natasha, if you didn't mind, what are some of the symptoms of endo that people might not be aware of but could be affecting them?
Right. Okay. So some common symptoms first maybe include painful menstrual cramps, painful sex, painful bowel movements, painful urination, and infertility. And as endometriosis is a systemic condition, meaning that it affects multiple organ systems, there may be some symptoms that people are not as aware of. So these symptoms include fatigue, as well as pain in non-pelvic regions of the body, so pain elsewhere in the body. And because, or in living with a chronic pain condition like endometriosis, may also have mental health consequences, such as depression and anxiety.
Gosh, yeah, it's amazing how wide the variety of symptoms can be, and probably things that a lot of women would have thought were just a normal part of your period really aren't that normal. Rachel, maybe we'll go over to you next. We had a question from our audience about endometriosis diagnosis and if anyone had been working on a non-invasive way. But let's maybe just kind of do the bigger question of what's involved in diagnosing endometriosis. And maybe you could speak to your own experience.
Sure, yeah. I mean, my diagnosis took quite a while. Mine took 11 years. I think on average it's around 7 usually. And so there's no easy road, but for me it was just kind of asking a lot of questions about why I was experiencing the kind of pain I was experiencing. And when it got acute, you know, I would go to the emergency room, which would kind of go on my patient list, you know, of things that I had done. And after enough times, it was kind of like, okay, we should investigate this. It really helps if you have a GP who's following you or a family doctor who's following you, who can kind of provide some consistency of care. He can bug over and over and say, hey, there's something going on here. And so for me, I got referred to an OB who, you know, suspected some cysts based on an ultrasound, and then did surgery and didn't diagnose me at first with endometriosis, and then on closer inspection of the results of the surgery to remove my cyst was like, oh, okay, this might be something else. She still didn't use the word though, so she sent me to someone else who did a laparoscopic surgery again, so I had a second surgery, and then that OB diagnosed me with endo and referred me to the Pelvic Pain Center at BC Women's, where I have had 2 subsequent surgeries, both to excise the tissue, and one was a complete and total hysterectomy. So my journey was quite long, but I think knowing what I know now, and if I had more information, could have been faster if I'd known the right questions to ask.
Yeah, that makes a lot of sense. Kate, could you maybe speak to the fact that the kind of 7 years is the median age? Why is it so hard to properly diagnose endometriosis?
Yeah, that's a really good question. I think I don't have lived experience of endometriosis. I'm a researcher, but I get to work with a lot of folks who have endo, and we hear a lot of stories like Rachel's, where, you know, someone has an issue, they try to seek care, they're kind of told there's nothing wrong here, and that cycle repeats itself until it gets either to some kind of extreme tipping point, or folks are lucky to find a healthcare provider that kind of listens to them and validates them and hears their concerns. So thinking about that diagnostic delay, sometimes the simple answer you hear is, well, there's no non-invasive test, like there's no blood test that can tell you have endo. We know that it can only be diagnosed definitively in surgery, and in some cases using specialized imaging. And that's definitely part of it, but I do think sort of the broader part goes far beyond that test, to the fact that societally we have these both taboos around the symptoms of endometriosis and this unfortunate tendency to normalize the symptoms. So if you imagine a young person who's gotten their first period, it's super painful, they might not straight away feel comfortable talking to someone about that, because we as a society have all decided periods are icky, we don't talk about that, it's gross. So the person might suffer for a while with those symptoms, but then when they do go on to talk to a trusted adult, like a healthcare provider, we hear so often that people are told, you know, that's part of being a woman, like that pain's normal, take some Tylenol and just sort of go with it. And that's backed up in the research. We know that 83% of people are told in their diagnostic journey that their pain's normal. So I think really those taboos and the normalization combine to bring us to a place where when people ask for help, they're not always getting the help that they need.
And just to kind of maybe like jump into that one audience question, have you heard anything in your research, or any of you, about them finding non-invasive diagnostic techniques?
Yeah, that's not the kind of research that I do. It does seem to be sort of a holy grail in endometriosis research, but as far as I know, there's nothing even remotely close to being a good diagnostic non-invasive test. I don't know, Natasha or Rachel, if you've heard otherwise. Again, it's not my area, but I'm pretty sure we're unfortunately quite far away from that.
One of the things that's been explored for when I've gone back as a recurring patient, because after surgeries, often mine would recur, is pain mapping. So internal ultrasounds with pain mapping to give a sense where pain is coming from, and if that might indicate, further investigation, or even maybe the assumption that it's endo, so to try some treatments for that. And then also working with some MRI radiologists to see if there are any characteristics of endo that can show up on MRI. So from what I understand from my surgeon, these are still relatively new, and things that are being put into place at centers that have kind of a focus and the right equipment, but that's not something that a GP or an ER doctor would be trained on. So finding that access to that kind of specialized diagnostic care is tricky.
Yeah, that's a really good point. And I guess, Rachel, I was thinking about like blood tests specifically, but it is true that there's been pretty significant advances in ultrasound and its ability to detect 2 of the 3 kinds of endo. So cysts on the ovaries, as well as those deep infiltrating lesions. We're really seeing advancements in the ability to diagnose those on ultrasound in expert hands. Unfortunately, as of now, that's not something that's accessible, like Rachel said, across Canada. And it also can't be used to rule out endometriosis. So just because you have a negative ultrasound doesn't mean that you don't have endometriosis. It can only be used to diagnose kind of those 2 subtypes.
Right. So there's a lot of limited options at the moment. Natasha, could we maybe go over with you what the possible treatments for endo are at the moment?
Yes. So I'm not a medical doctor, so I'm just going to give kind of a brief overview of some of the treatment options. And the treatment plan really depends on what people are presenting with, so what symptoms they have, as well as their individual preferences and side effects that they feel comfortable managing. So some treatment options may include medical therapy, such as hormonal contraceptives given continuously. IVF can be used if a person is trying to get pregnant. Surgery is another treatment option, like Rachel said. Includes the removal of the endometriosis tissue. And other important therapies to consider include floor physiotherapy, counseling, and pain education. And so one model for kind of integrating all of these options is a multidisciplinary approach that includes medical, surgical, and complementary therapies together in the treatment plan. So that's kind of just a brief overview of the treatments, and I'll pass it to Rachel if you're comfortable telling us a little bit about your specific journey and decision making for treatments.
Yeah, for sure. I think out of all of them, I've tried them all at various times and sometimes overlapping. So the first things that were tried for me were hormonal birth control, just to see if my cycle could be regulated a little bit more and maybe suppressed a little bit. So I went on just regular birth control, I think when I was 16, and then continuous birth control to try to kind of like stop the period from happening. Although for me, the pain was never just my period. That is the way for some people. For me, it was just all the time. And then I went on some of the hormonal treatments that are not specifically birth control designed, but they're still hormonal treatments to suppress periods. I had an IUD, I had a Mirena IUD, and then eventually went surgical. And then I did the pain education program through the Pelvic Pain Center to talk about how pain affects your brain and your psychology, and the things that you can do to break a pain cycle. Your physiology and your mental space are connected on that front. And then I did some counseling as well. I've seen a therapist for quite a while, and so run the gamut, I suppose. And the decision making really depends on what's happening in your life, how much your pain is affecting you on a day-to-day basis, how much fertility is in the conversation for you, and whether you're trying to get pregnant or you want to preserve the possibility of getting pregnant if that's something you're interested in, or just in general, like for me, I wanted to preserve just I wasn't actively trying to become pregnant, but I wanted to preserve my body the way that it was until I felt like that wasn't an option anymore. So it was a very personal thing for me, and for everybody that I've spoken to on that front. The decision making is really wide ranging, and I'm very active in my work. So for me, it was always, what can I do to maintain doing what I love in my life and making my life functional for myself? And what are the best options for that, which for me eventually became surgical.
Thank you. So next I'd like to start with Kate, and we'll go back to Rachel. If we could just talk about what some of the biggest barriers are to receiving care in Canada at the moment.
Yeah, that's a really good question. And I always think about this kind of in two levels. I think the first is sort of awareness among primary healthcare providers, right? So we've talked about how that can really cause a delay to diagnosis. And I think also in terms of understanding appropriate management, we need to do more work to support our primary care providers in understanding the disease, how it's managed, and also when to refer patients to further care and where to refer them, like what the appropriate pathway is. So I think the primary care, your family doctor, what they know or don't know, that's one sort of tranche of barriers. I think the second point is access to some of those more specialized services that we've been talking about, like surgery or multidisciplinary pain management. We know that in Canada, people are waiting at this point, in some cases years, to get the surgical care that they need. And those wait times they don't necessarily reflect the number of specialized surgeons in Canada, but they do reflect the fact that those surgeons sometimes have a hard time accessing OR time. So they don't have enough time in the OR to care for the people who need care. And that problem has really reached such a point that people are making really tough decisions about whether they're going to cash in their savings or put a mortgage on their house or borrow money from friends and family to go internationally to get that standard surgical care. So nothing experimental, just sort of standard care. And I think that's such a red flag from my perspective in terms of health service and delivery policy, in terms of the fact that we need to be thinking about how we're prioritizing this care and making change. And I guess the last point would just be, Rachel, you talked about, counseling, physio, those kinds of things. Unless you're in a center like the Center for Pelvic Pain and Endo in BC, most people are paying out of pocket for that. And obviously that's a huge barrier for folks to get all of the care that they need. So I think those are sort of 3 points where access is difficult. I don't know, Rachel, if that sort of reflects what your experience was.
Yeah, definitely. I think, what the point you made about GPs, I would extend to ER docs as well, because so many people in the middle of a flare-up have no other option but to go to the emergency room because the pain gets so excruciating that you don't really know what to do. And almost every ER doctor I've encountered either has heard of it adjacently, but doesn't really and I get it. There's so many things to treat in the emergency room, but it's something that gets brushed off very frequently. And the responses I've gotten at the emergency room have ranged from, well, I'm really sorry this is happening, there's nothing we can do, to you're a straight up drug seeker, which is unfortunate that that's the response. But it is. And then I'm not the only one who's experienced that. So I think that education piece is so important. But that goes on the patient side as well. As I mentioned before, if I'd known certain questions to ask and certain ways to phrase, this pain isn't normal, this is not what I should be experiencing, this is what's happening to me, every time that it comes up, and just to kind of advocate in that way, I would have had a different experience, I think. So, there's a lot of education on both sides that needs to happen.
Yeah, a long way to go. It's great that we're doing things like this and the work that you all do to make people more aware, because up to 10% of the population, or 13, it's the numbers are high. They're too high for it not to be known about. Kate, could you tell us what the potential dangers of endometriosis going untreated are?
Yeah, so you won't be surprised by the fact that there's a negative relationship between being undiagnosed or going untreated and outcomes in terms of endometriosis. So sort of first, we know that there's the potential for the disease to progress, and that can affect, like Natasha said, multiple body systems, cause organ damage, lead to increasingly complex chronic pain, all things that become more and more difficult to undo or sort of restore to a healthy, normal state. that's obviously related to a decreasing quality of life. So if you're living with chronic pain, you can't go to work, like do the job that you love. Like Rachel, you have a harder time going out to see your friends, your relationships suffer. Like it's across the board, sort of a decreasing quality of life, and that's horrible that people have to go through that as a consequence of not being adequately managed. And then I think hand in hand with that goes poor mental health. So we know that folks who are living with unmanaged endometriosis have higher rates of depression, anxiety, and PTSD. So again, just a function of living with unmanaged symptoms of a really tough disease. And I think if you're thinking about people who are undiagnosed, they're having those experiences, and they're also having additional difficulties getting the accommodations they need at school and work, right? So if you're saying at work, like, oh, or at school, you know, I can't come to class today, I can't do this test, I'm super sick, it's my period. Like we've all seen that trope, right? Like you're just trying to get out of it, So without having the diagnosis, it's hard to get those accommodations, and it's hard to access the specialist care that you need. So I think, yeah, that's why timely diagnosis and management is so vital for the endometriosis community.
Yeah, definitely. Kate, or sorry, not Kate, Natasha. We haven't heard from you in a while. For the quarter. We've already spoken to a bit of it, but could you maybe expand a little bit on the major barriers towards more extensive endometriosis research?
Yes, absolutely. So I would say probably that, in my opinion, the biggest issue or barrier to more endometriosis research is funding, specifically when we're talking about women's health research, which is really underfunded and under-researched. And as an example, if we compare endometriosis, a condition that affects approximately 10% of women and an unknown number of diverse people, to a condition like IBD, inflammatory bowel disease, that affects approximately 0.7% of people of all genders. So we see that despite these differences in prevalence, the Canadian research funding has awarded approximately $43 million to IBD research, compared to only approximately $8 million to endometriosis research since 2009. So this is just one example of this discrepancy, this lack of women's health research funding. And another example I wanted to share is the work from Dr. Lisa Glia. She led some great work looking at research bias in British Columbia, and found that women's health research was funded less often for shorter periods of time, and for lower funding amounts. So just another example of results that are showing this decrease in women research funding. So that being said, there are strides to improve women's health research funding in Canada. So for example, the Government of Canada launched the National Women's Health Research Initiative, which includes some funding opportunities that will help drive research to improve the health of girls, women, and gender people, to ultimately ensure access to evidence-based, culturally safe, and gender sensitive, and high quality care for all people living with this condition. So that's one barrier, I would say, definitely a big one in terms of barriers go. And a second barrier that I wanted to talk about is representation in research. So sometimes it's difficult to reach the people that you're targeting in your research. So for example, historically, endometriosis has been studied in middle-class white women. And we don't actually have a lot of information about the experiences of other groups of people. And to get a full picture of this condition of endometriosis, it's important that we're including all people who experience this disease. And so for us as researchers, it's really important for us to build trust with the communities and to make sure we're answering research questions that are important to these groups of people. So those are just barriers to us as researchers, lack of funding and representation research.
Thanks, Natasha. So let's go back to you, Rachel. With your lived experience, if someone suspects they have endo or they're experiencing pain, what are some of the first steps they should consider?
I think immediately trying to talk to a practitioner about this so that you can get the process started. If you can start with your family doctor, if you don't have one, if there's a walk-in doctor that you can talk to that can refer you to an OB, just to get the process started. And another thing to keep in mind is to, I've just started doing this after 20 some years, to log your symptoms. Somebody told me that early on and I was like, yeah, okay, totally have time for that. And I didn't do it. And I wish I had, because just having that organized, like, you can see the patterns yourself. So you're not relying on a practitioner to look at the patterns for you, but you're taking an active stance in your own care to say, this is what I'm seeing. This is what's happening for me daily, weekly, monthly, and this is how I know it's not okay. It's a very kind of empowering step to take as a patient, but there's also a lot more resources online available just for educational purposes. There are definitely a lot of books that have been written from people with lived experience. There are websites like, that outline symptoms, that talk about, what it looks like, what it might feel like. There are support groups on Facebook, and you can get in contact with some, places via social media that have other people with lived experience to ask questions. And so I think getting started on all three fronts with that kind of self-education, self-awareness of what's going on, and then speaking to a practitioner, and just don't lose hope if the first thing they say is, well, I don't know, we have to see, because it can be daunting in the face of pain. But to get that process started and to just really be proactive is the best way to move forward as a patient.
Yeah, it seems like a lot of the time in healthcare now, we have to be our own advocates and really be that squeaky wheel to get the attention that we need. Let's go over to Kate next. This question's for all of you, but we'll start with Kate because you haven't talked in a while. Could you, each one of you, provide one thing that could be helpful in improving endo care?
Yeah, so as you may have picked up on in some of my answers, I'm a big sort of believer that governments have sort of a responsibility to take when it comes to improving endometriosis care. Changes like reducing surgical wait times, that's not in the control of any one surgeon or hospital. That requires funding and staffing, and that money comes from government. So I think if we want to do things like improve those wait times, like get more money for research, like make sure healthcare professionals are well trained, and that we're also educating the public about menstrual health and endometriosis, that government advocacy is kind of a key action, getting in touch with sort of provincial and federal elected officials and just saying, this is a situation and this really needs to change.
Who would like to go? Oh, let's go with Natasha next.
Sure, I can go next. Thank you. Yeah, so as we've talked about so far, we know that one of the factors that play a role in the diagnosis of endometriosis is lack of healthcare provider knowledge and awareness of the condition and its symptoms. So improving education for healthcare providers on what the symptoms are, what's normal, what's not normal, what the standard of care is for the diagnosis and treatment of endometriosis is really important for the timely and appropriate care for people with this condition. And currently in my postdoctoral work, we're actually doing this. So I'm working with a group of amazing experts, including people with lived experience with endometriosis, as well as student partners. And we're exploring knowledge needs of medical and nurse practitioner students to kind of get a baseline understanding of what their knowledge is of endometriosis, chronic pelvic pain. And then based on what we find, in using this information to inform the development of an educational resource. And we're going to be creating a virtual case resource for medical and nurse practitioner students to help improve their understanding and also ultimately to improve the care of their future patients. So I think education for healthcare providers is one way we can improve endo care.
And Rachel, what would you say?
Well, I agree with both Natasha and Kate's excellent points, and I think I would also say that if we could teach reproductive health differently in school, so that people know about what is like normal and what is pain that is not normal. I think that's a first place to start. I'd also like to see more patient partners across hospital care in emergency departments specifically. I wish that patients were consulted as partners in terms of physician education, because serving on the patient advisory board and being able to speak directly to certain things that are brought up, it's such a great collaboration. It's rewarding as a patient because you see how hard practitioners are working to make a difference. And excuse me, it gives you a different perspective on than sometimes the salty way that you leave an appointment when it went badly. But also you get to say, hey, and here's the piece that you're missing from my perspective, or that would come up for me or other people. You know, and I've been very privileged to do that and to be able to access that. But I think educating doctors who are first responders, like in the ER or at a GP level, is really essential.
Well, we've been a lot quicker than we thought we were going to be. Is there anything else any of you wanted to bring up about endometriosis that we didn't have a chance to discuss before we kind of do all your sign-offs?
Yeah, I just saw someone ask in the comments, how does someone do that? And I think it's a question about like, how do you become a patient partner in research, which I think is a really good question. And maybe we could just, talk about what that looks like at the Center for Pelvic Pain and Endo and how we think it might work at other centers. I can start us off. So the Center for Pelvic Pain and Endometriosis has had a patient research advisory board for, I want to say 7 years now. It's a group of folks like Rachel who have received care at the center and who provide like meaningful guidance and partnership on the research that goes on at that center. We can get into maybe a little bit what that partnership is like, but just to flag that I think that advisory board structure is quite specific to the center. But I think it's always something that you can raise if you are a patient getting care at an academic center, so somewhere that's affiliated with a university. If you're in a clinical appointment, you can always flag to your provider, I'd love to contribute, I'd love to help out, do you do research? You know, if you're ever looking for an advisor, I'd be interested to participate in that way. I think a lot of clinician researchers are keen to do that kind of work, but maybe aren't like totally sure how to get started. So if they're already doing it, they might take you up on it. And if they're not, it might be the nudge they need to start bringing sort of a more active patient voice into their research. But yeah, Rachel, I don't know if you want to chat a little bit about what that's been like for you.
Yeah, I mean, I think ours is an invitation board. So we recruit when we need new members in specific ways, and then you take a spot if it's offered. So for me, that's meant being part of looking at grant proposals, giving feedback on grant proposals, kind of saying, hey, here's where this doesn't match with the patient experience. Here's where, you know, you might be missing some, as Natasha was saying, some representation pieces. Our board is becoming more and more diverse, which is really encouraging to see. And then it also just gives you access to like what's being done. So like we come up with initiatives, we pitch, like we are pitching, you know, some of our practitioners on grants, on proposals, which was really cool. And I mean, I'm sure our days are a little off the wall, but it might spark something else. And then something I also do just independently is if I see the opportunity to be part of a study, if I fit the bill for a study that's going on, like I've had, you know, requests from the tissue bank when I've had surgeries for my tissue to be used as part of research studies, I always say yes, because I'm like, if some part of this mess can help somebody else, I just want to be part of the solution in any possible way. So if I get a chance to volunteer for studies or see a notice board up at the clinic or online, I'm always looking for a way to be proactive and active, because I'm not a doctor, but I can help as a patient. So, and a lot of those things are now posted on social. You know, if a study's happening, if you're following like women's health research clusters or anything like that, you'll see those notifications, and getting involved that way can be really beneficial on both sides.
I want to hear more about your off-the-wall ideas, but I don't know if those are confidential for now.
I was pitching simulations. I was like, oh, we should do educational simulations with the tech that's at the center for doctors to come in, be able to use the tech and like the ultrasounds and like simulate, because you know it's active experience. But if somebody wanted to fund that as a grant, it's both education, but it's like active participation at the same time. So I was getting very excited about something that I have no idea if it could happen. But
I love that.
That's amazing.
Just like writing this down.
Well, Rachel, yeah, right now.
Yeah, I mean, I think this is exactly like you called it off the wall, but that to me sounds like something that probably could be done that maybe, you know, folks just haven't thought about or haven't put high on the priority list yet. I know with the Patient Research Advisory Board a few years ago, members of the board brought up the idea of doing menstrual health and endometriosis education in schools to try and address some of those issues we've been talking about. That wasn't on our radar, and we ended up doing it. Like, it was amazing, and the research turned out, I would say, 10, 20, 30 times better than it would have if it had just been researchers kind of trying to figure out what the best path forward was. So yeah, speaking as a researcher, love it. I think it only makes my work better and more fun, and I learn more, and I feel like it has a greater chance of impact. So yeah, when those opportunities arise, I think they're super great. And I know, Natasha, you've got some experience with, well, lots of experience doing that kind of work too.
Yeah, we did have a workshop. We've created educational videos for patients, all in collaboration with patient partners, which has been an amazing experience. And I also did want to add to Rachel, your point about social media. I just want to point out that Twitter is a good platform for researchers. And if you follow research labs, that's often a place where we post about looking for research participants or patient partners, and things like that. So that's a good place to keep an eye out for.
Assuming Twitter doesn't implode one of these days, which we'll see.
Here, who knows? Was there anything else that anyone would like to cover before we kind of like see what you guys all want to promote? Or I think we covered a lot of stuff today, so I honestly really appreciate all three of you and bringing your expertise to our audience, because it is a topic that is so important and we really want to bring a lot more attention to. So let's just kind of go around the circle. We'll start with who talked last. We'll start with Rachel. And where can viewers find you? Is there anything you'd like to promote?
You can find me on Instagram at HeyRachLanger. I'm also on Twitter. I think it's just at RachLanger, but I don't do much on there. I retweet Kate and Natasha a lot. And I just would say, if anybody's interested in helping with funding, the BC Women's Foundation does a lot of amazing research, and it helps fund directly what we do on the Patient Research Advisory Board and some of the grants that we can put forward and speak to. So there's fundraising pages to donate. If you're interested in donating, they do really great work.
Thank you. And Kate, what would you like to promote?
Yeah, so you can find me personally at Kate J. Wahl on social media. And if you're interested in doing, like, writing a letter to your member of parliament or your provincial representative, MPP, MLA, whatever it's called in your province, you can go to endoactcanada.ca. There's a completely customizable letter for both federal and provincial governments that you can just copy, paste into your email, add whatever it is you want to add, and click send. And that's one sort of seamless pathway for just getting government action going. I thought Rachel was going to shout this out, but maybe you're too shy. Rachel works on the show, now the name's completely slipped my mind, Transplant, right? Yes, which has one of the best endometriosis episodes ever to be seen on TV. So if you're looking for good media representations of endometriosis as a lived experience, that episode is definitely one to go for, and it's thanks to Rachel's expertise.
Thank you. That's so nice.
Thanks, Kate. Natasha, where can people find you, and what would you like?
Twitter is where people can find me at Natasha Orr. And the one thing I want to point out is our center has a great website called Sex Pain Endometriosis. So you can check out the site for more information and resources. And you can also follow the center at Pelvic Pain and Endo on Twitter, and we post a lot about endometriosis as well as studies. So you can follow up. And I love transplant, so everybody should watch it.
I've got
You guys.
Oh, I've been hearing so many good things.
It's amazing. Yeah.
And our experts did give us a big list of resources, so don't worry about writing them down right now. We've got something up on our website. If you go to ScienceUpFirst.com/endo, you can find everything there. That's ScienceUpFirst.com/endo, and all the links will be there for you. And so thank you three again. I appreciate it so much for taking time out of your busy days to talk with us today.
Thanks so much.
Thank you.
This was fun.
Thank you. Have a great day.
Bye.
Bye.